Welcome to the Precision Medicine session. My name's Sayali Pedharkar. I'm Deputy Chief Science Advisor at Manatū Hauora, the Ministry of Health, and I'm co-chairing today's session with Professor Peter Larson. He will chair the second half of this session. So I'll provide a very brief overview of precision medicine from Ministry of Health's perspective. Get that to work. Okay. So, as many of you may know, the Ministry of Health published its first long-term insights briefing in August last year, which was focused on precision health and the challenges and opportunities we may experience in implementing it here in New Zealand. Why did we think precision medicine was a good topic? Why did we think the time was right? And it was largely because, like everywhere else, we are experiencing unprecedented pressures on our healthcare system. The costs of services and our fiscal constraints, the pressure on workforce, access to services or lack of for those who need it when they need it. When we combine this with the demands of an aging population, our changing demographics and emerging health threats, like climate change, antimicrobial resistance, it really highlights the need to act, probably more so now than ever before, and the need for us to be prepared for the changing trajectories of health and well-being outcomes for our people. The health reforms were a step towards addressing some of these issues, but those alone are not enough. What precision medicine does is it gives us an opportunity to provide different models of care so we can prevent illness and provide timely and targeted intervention. Having said that, it's important to note that precision medicine isn't a new concept. The UK, US, Singapore, Australia have been doing work in this space for the last 10 years. It's also not fair to say that we don't have any work underway in this space in New Zealand. We have some excellent initiatives, and we'll hear about some of them shortly. But what we don't yet have is a national cohesive strategy on precision medicine. What that might look like is the key players like governments, ourselves, te whakaora, communities, te tiriti, and Māori leaders, Pacific people, other underserved communities, but also our academics and scientists and clinical laboratory workforce and industry to come together so that we can lay the building blocks that are necessary for us to implement precision medicine and achieve a collective vision of Paiora. What are some of those enablers or building blocks? We're looking at things like legislation, governance, we're looking at ethics, privacy, we're looking at regulatory mechanisms that will enable us to keep our people safe, minimize the risk of genetic discrimination. We're looking at data. Do we have the right data governance and sovereignty principles in place? Do we have the necessary infrastructure to deliver and make precision medicine accessible equitably across the country? We're looking at research and innovation, the role that plays in informing and driving improved outcomes, and how we might feed that and evaluation back into our healthcare system so we can truly embed precision medicine as a service. We're also looking at financial sustainability. So I mentioned fiscal constraints briefly earlier. How do we inject funding at the very beginning of an initiative, but how do we sustain it and how do we prioritize it amongst many other needs and demands on the healthcare system? Those are a lot of questions, but I think they're an essential part of how we can work towards implementing and enabling the uptake of something like precision medicine so we can drive improved health and well-being outcomes. So where to from here? We're taking small steps within the ministry. We recently established a Chief Advisor Precision Health role. We hope the individual that gets in this role is able to work off international evidence, draw it together to inform our work program. This person will also play an important part in building, strengthening, and establishing new and existing relationships with our community leaders, with international partners. And collectively, I hope it's one step towards realizing a shared vision and that is to improve capacity and capability in accurately diagnosing, screening, and treating our people who may present with life-compromising and life-threatening conditions. That allows me to segue quite nicely into introducing our speakers in the next theme, which is improving cancer diagnosis and treatment with circulating tumour DNA. And it's my honour to introduce Professor Parry Guilford, who is the leader of, who's the Deputy Director of Healthier Lives, is a leader of its precision medicine research theme. Parry is a Professor of Cancer Genetics at University of Otago in Dunedin. He's co-founded the cancer diagnostics company Pacific Edge Limited and is a board member of our Health Research Council. Parry will talk about the precision medicine theme and the project he co-leads with Healthier Lives. The project focuses on investing ctDNA that can improve cancer diagnosis and treatment and provide more equitable access to cancer care. Parry will be joined by his PhD student, Jordon Lima, who will talk about exploring the experiences of Ngāti Porou cancer patients, their whānau and their cancer care providers, and determining how precision medicine technologies could improve cancer diagnostics and surveillance for Ngāti Porou communities. I'm also honoured to introduce Professor Cris who will speak after that. Cris is a co-principal investigator on the ctDNA project. He leads a cross-disciplinary research team of clinicians, biologists, and data scientists at the University of Auckland. His team uses genomics and bioinformatics to better understand human disease, particularly cancer. Cris will be joined by Dr. Sandra Fitzgerald, a research fellow in his group. Sandra's research includes developing new methods for monitoring cancer treatment and particularly helping improve access to care for patients in rural areas. Thank you.
Kia ora koutou. Thank you, Sayali, very much for the kind introduction. It's my pleasure to introduce the precision medicine theme, which comprises two groups, a group in cardiovascular disease and our own cancer group. The big green button, I know, is the one to push. Before I get into some of our results for the cancer part of the theme, just want to reiterate some of the words that Jerry mentioned this morning about features of the Healthier Lives Science Challenge that we've found to be incredibly useful and very productive. He mentioned, of course, the co-governance, which has worked extremely well for all parties. But I think a really major part of the challenges has been the deep community engagement. So we're only doing research that people want. The challenge goes on beyond just introducing new ideas into the science ecosystem. So we see a lot of that with the Marsden, some of the HRC's, MB Smart ideas, new ideas come into the system, but it's very hard to keep those ideas alive. But what Healthier Lives has done through its lifetime has really supported projects right through to implementation. And this is by using various mechanisms to support that research, be it help with peer review, help with comms and getting the message out to stakeholders, and also funding mechanisms as well. So I'd like to really acknowledge what I think was a tremendous system for getting research done in this country and providing a real return on investment. So the basic problem with healthcare, in my view, these days, is that we're currently using largely a system which is population-based medicine, where the treatments or interventions are optimised for the average patient. And looking around this room, I don't see many people here who are average, maybe one or two, but mostly we're not average. And even worse is that it's really not only just the average person, it's the average person who gets into a clinical trial. And most of those clinical trials are done in the US or in Europe, and so you're going to find very few Maori and Pacific people involved in any kind of clinical trials. So we need to have a system which can change and better encompass the vast human variation that exists. So fortunately now there are all these new technologies coming through which enable us to start to do that, to give ways to individualised risk assessment and treatment. And that, of course, is the heart of precision medicine. With cardiovascular disease, there are a couple of big things there in terms of variation. One is the wide variation in individual exposures to risk factors. There's also vast genetic variation, which modifies the impact of risk factors. And so, one of the major goals of precision medicine in the CVD space is to try and quantify individual exposures and subsequent disease risk, and also determine targeted lifestyle interventions and treatments. And we'll hear a bit more about that when Anna and Greg get up to speak in a little while. Cancer, of course, is the utter pinnacle of variability and complexity. There are tens of millions of cells per tumour. Most of those cells have their own potential to develop independently down different genetic pathways. There are hundreds of different mutations which are capable of driving growth in a tumour. And tumours are not static, they evolve with time. So the genetic variation in an early tumour is different to that of a larger tumour. And of course, this means there are dozens and dozens of potential treatments for every single cancer type. So the goals for precision medicine in the cancer space are to identify dominant mutations in each patient and determine subsequent drug sensitivities, and also develop methods to rapidly assess how well treatment is working. So with that, I'll move on to introducing our circulating tumour DNA research. And we've got, as Sayali mentioned earlier, we've got a few speakers. I'll introduce ctDNA, circulating tumour DNA. Jordon will tell us about her work with Ngāti Porou, trying to understand their perspective on cancer care and circulating tumour DNA. We'll hear from Sandra Fitzgerald, who will tell us a lot about the new research which is coming out of the early stuff we did as part of the challenge. And Cris will try and wrap it all together and show how ctDNA fits into the wider precision medicine ecosystem. All right, so circulating tumour DNA refers to DNA which is released from a tumour into the bloodstream. And there it mixes with a background of DNA from other cells. And you can identify the tumour DNA by searching for mutations in the DNA sequence or changes to the methylation of the DNA. The amazing thing about circulating tumour DNA, it's highly specific for cancer. And what it does is gives you a very accurate measure of tumour burden. So how can ctDNA help cancer patients? Well, there's numerous applications throughout the lifetime of or the life course of a patient's disease. It can be involved in both the initial diagnosis. It can have a role in trying to clarify uncertain CT or MRI findings. For example, there may be a shadow on an MRI scan which may or may not be cancer. The ctDNA can help confirm that diagnosis. It can be used to identify drug targets when a biopsy of the tumour is not possible. You can use it to monitor treatment response. So the idea being to try and avoid futile treatment, only give treatments which are showing a promising or useful effect in individual patients. In principle, you can use it to design maintenance therapies. So you could titrate drug doses down and drug types down this is for patients who have very advanced disease where cure is no longer possible. Titrate the drugs down so that they have as long a life with as high a quality of life as possible. And you can do that if you keep a very close eye on the tumour burden using circulating tumour DNA. I think you can use it to rapidly assess new treatments. So if you have a patient with a complex tumour and there are numerous drug possibilities, I think often clinicians are very nervous to try and choose one because they are concerned that by the time they've got to a CT scan scheduled in 8 to 10 to 12 weeks, then that cancer may have progressed. But if you have a very rapid readout from a simple blood test, you've got more chance to be nimble, to be fleet of foot with your treatment. You can change it, you can modify it rapidly and ensure the patient is not ever receiving any futile treatment. And you can try things which are a little bit more edgy, for which there may be less data to support them. And finally, you can use it to monitor tumour evolution. So as I mentioned, the tumour will evolve through time, and by looking at the blood samples from a patient, you can see what those changes are and make changes to the drugs that the patient's receiving. So for us, very importantly, from Lumsden to Vava'u, it's all about improving access to cancer care. So being a simple blood test, it's very accessible and very cost effective. And I think importantly, it provides a means to be proactive. So for families, individuals who are concerned about their health risk, they can go out and get a simple blood test to tell them what their cancer diagnosis or state might be. Currently, there's major barriers with access to many of the diagnostic modalities for cancer because of shortages in staff and the cost and the time to do these, and therefore people struggle to take their own fates in their own hands, and they have to sit back and wait for the system to say they can or cannot undergo a cancer workup. But we believe with ctDNA, people can be more proactive. If they're concerned about their health or their family's health, they can have a simple blood test to confirm or exclude a cancer diagnosis. And the nice thing about ctDNA is because it's very specific, it's not going to really cause an undue burden on the healthcare system. We're not going to throw up dozens and dozens and dozens of false positives which have to be sifted through by the healthcare system. So all in all, this should reduce the reliance on large hospitals, and it should lead to better care of isolated or rural communities, be it Vava'u or Lumsden. And this, of course, will all lead to reduced inequities. All right, so it's now my pleasure to introduce the next speaker in the session, Jordon Lima, who is doing a PhD on this project. She's a bit tired. She just flew in from the US yesterday, but I'm sure she'll get it together for a few minutes for us. Thanks, Jordon.
So thank you, Parry, for that introduction. I'm glad that he told you that I had jet lag, just in case anything goes wrong in this talk, and then I can blame everything on that. So kia ora koutou katoa, ko hikarangi te maunga, ko waipu te awa, ko Ngāti Porou me te aitanga hauiti ngā iwi, ko Jordon Lima tōku ingoa. So I am in the third and hopefully final year of my PhD, which is generously funded by the Health Research Council of New Zealand by a Māori Health Research PhD scholarship. So I'm actually in the final 6 months of my project. I know, Parry's looking at me shocked, where did the time all go? And so hopefully this gives me a good opportunity to summarise the results of my qualitative side of the research. So not only am I supervised by Parry in the Centre for Cancer Genetics in the Cancer Genetics Laboratory, but I'm also supervised by Associate Professor Karen Paringatai in Te Tumu, the School of Māori Pacific and Indigenous Studies in Dunedin at Otago University. And it's the first time that a PhD student has been supervised between those two departments. So I'm kind of just making this up as I go. So I wanted to start first with how my research is structured, and so I don't need to tell anyone here the importance of kaupapa Māori research and the equitable health outcomes that it results in for our Māori peoples. But we know for a fact that Māori ethnicity is an independent risk factor for poorer health outcomes here in Aotearoa, New Zealand, and that kaupapa Māori research privilege is a Māori worldview, and then that leads to better outcomes for our people. So not only am I doing kaupapa Māori research, but I'm actually doing kaupapa Ngāti Porou research. So I am Māori, but I am Ngāti Porou first and foremost, which you'll probably hear from everyone from Ngāti Porou. We love to tell everyone that. And so it's not that I'm looking for the applications of ctDNA to Māori communities. Obviously, that's going to be an outcome of the research, but more specifically, I'm working with my communities in Ngāti Porou on Te Tai Rāwhiti to figure out how ctDNA would work for us and our populations in the realities that we have. So I'm using my background in biomedical research and my scientific brain to address ctDNA, but I'm going into my communities and asking them, hey, if we develop this test, if we get it up and working, are you going to use it? And I can tell you a little bit about what they've said so far. So I'm doing narrative interviews with Ngāti Porou Māori cancer patients that are not currently undergoing treatment, and they've had treatment in the past 10 years. I'm also interviewing their whānau who have supported them during this time, because we know that they have different lived experiences and they experience the treatment process in like a different reality. But they often remember a lot of things that patients don't, and they have a lot to say about the type of care that they expect. I'm also interviewing their cancer care providers, and I've been joking that I am lucky enough to be interviewing cancer care providers on Te Tai Rāwhiti because there's only 2 of them. So it means I don't have to do as many interviews as I might have to if I was based in Auckland. So I'm interviewing the oncology nurse that we have in the Gisborne Hospital and the single oncologist that provides the tairawhiti, who is based in Hamilton. I'm also going back tomorrow? No, the next day, to interview a primary healthcare provider as well, because I've noticed that secondary, tertiary, and primary are all going to have different expectations of care and realities, and they're going to feed back into how ctDNA can be used and what that might look like for their patients in different ways. So not only am I interviewing patients and their whānau members, but also clinicians. And I am multidisciplinary, so this is only half of my PhD project, as it probably should have been a full PhD project. But we'll do 2 in 1, a bargain for you. So the narrative guidance, so rather than going in with questions and asking them specifically anything, I go in, I introduce myself, I say what this research is, and then I ask them about how their care goes. For the clinicians, I ask them about what are the general experiences that they see in the community, and then we kind of like end up at ctDNA towards the end. So we say like, oh wow, so you've said something about how accessibility could be improved. What would you think of a blood test? And then they have their own questions, and I say, well, if the blood test was based on DNA, what other questions would you have? We talk about education in the community, how you might communicate, all these types of things. And then I will do inductive thematic analysis, which means that the themes kind of just evolve from the narratives that I get. And then hopefully I can feed back to presentations like this, where I can say what it is that patients and clinicians expect. So patient experiences so far in Ngāti Porou is that cancer is the C word. So if we are going into communities and we're introducing a test for early diagnostics of cancer, for example, something that ctDNA has the potential to do, we're going to be diagnosing a lot more cancers. And anyone diagnosed with a cancer in Ngāti Porou instantly gets the fear of the C word. So that's something that I noticed first and foremost is a mindset that we're going to have to change. And I know that there's been a lot of really good kōrero about how just a small shift in perspective and the way that someone views something can lead to big change. So for Ngāti Porou, there needs to be some kind of shift in the way that we view cancer as not this disease that once you get it, you're immediately going to die. There needs to be some way to communicate to people that it is treatable, it is more treatable when it is diagnosed earlier. And so yes, there is going to be an increase in cancer diagnoses, but what does that mean for you? For them, they don't trust scientists. Crazy. It's wild that the first thing that the thing that I don't say when I step onto the marae is, hi, I'm Jordon, I'm a scientist. The first thing that I tell them is that I am from Ngāti Porou, that I am Te Haitanga Hauiti, that this is where my grandparents are from, that these are my marae. That is who I am first and foremost. And then the science is kind of just something that I work into conversations in the background. So they don't realize that they're learning. None of us realize that we're talking about science because we all have the same common goal at the end, which is to make sure that our people live longer and healthier lives. So when it comes to trusting the people, that's the biggest thing for us before they can trust the test. If they trust the people, which like for me, their moko, I can tell them to go out and walk for an extra 20 minutes a day and it'll reduce their risk of diabetes by 13%. I'm immediately going to tell them when I get there. And they will trust that because we are whānau and we lead with that. So rather than leading with the test, obviously the science needs to be able to back it up, and Cris and Sandra will be able to talk to how we're making that sensitive, reliable and specific. But they need to trust the people that are asking them to take these tests. They need to trust the people that are going to give them this cancer diagnosis and trust that they're going to get them the treatment that they need so that they can live with a cancer diagnosis. A lot of them say, I don't have time to have cancer, which is, initially very entertaining. None of us have the time to have cancer diagnoses. But the high cost of living, the bridges being washed out by the slash in the rivers, so many things, right? They don't have time to have cancer. They need to go to work. They can't go in for chemotherapy and radiation because it means that they have to take weeks off work. They can't travel to Hamilton because they've got to go to work. They've got to put food on the table for their families. So how do we change these mindsets and tell them that if they come in to get a ctDNA test, we can give them an earlier diagnosis or we can give them more specific treatment so that they can get back to work and put the food on the table for their families, hopefully healthy food. When it comes to interviewing the clinicians, we talk a lot about benefit versus burden. So it's all well and good to say that we have these ctDNA tests, they can diagnose your cancers earlier, they can tell you when you're going into remission, they can keep an eye on your disease more closely. But if it's not going to change the course of their treatment, then it is only providing them an additional burden to say that their ctDNA levels are going up when you can't offer them anything else. So how do we work that in with the therapies that we have available, with the therapies that are funded, and with what the clinicians can do? In terms of screening versus surveillance, because ctDNA relies on the number of copies that are in your bloodstream, it means that early diagnosis is not currently super specific. So it looks like it'll be better for surveillance. The biggest thing that comes out of the interviews with the clinicians is that there needs to be some kind of step between the National Bowel Screening Program and colonoscopies. So everyone that comes back with a positive fecal occult test from the National Bowel Screening Program is then referred for a colonoscopy. And only 13% of those people that go for those colonoscopies will have cancers. So there's 86% of those people are going through for colonoscopies that they don't need, that cost the healthcare system quite a lot, and it's also a very traumatic process for patients. Nobody likes to have a colonoscopy. So it is possible for ctDNA to exist as an intermediary. So you have a positive fecal occult test, you go away for a ctDNA test, and we can then start to stratify patients by need, and hopefully just filter out a bunch of people that have blood in the stool for unrelated reasons. In terms of, I guess those are the biggest stories that have come through with those Ngāti Porou narratives. And when I ask them questions about kaupapa Māori research, a lot of my Māori, well, all of my participants are Māori, the ones that have had cancer. None of them say that, like, I want my clinician to operate in a kaupapa Māori principle, do it by doing this, this, and this. They say things like, we want open communication. We want them to treat us like a person rather than a number. They say they don't need to kōrero te reo Māori, they just need to kōrero in a way that I understand. So it is not that we need every GP and practitioner on Te Tai Rāwhiti to kōrero te reo Māori. We just need them to speak in the way that their patients understand. We need their patients to want to go in to see them in the first place. We want them to have rapport. Which is a great thing about Tai Rāwhiti at the moment, is that the nurse practitioner that is there, she's been there for 40 years. She was born on the coast, born and raised. And so every patient that she has coming through, she knows them and they know her and they have that close relationship. The only time that they need to go and see their oncologist in Hamilton is if they need some kind of like tertiary treatment. And when it comes to ctDNA, it's going to be a similar thing. It's going to be about communication. It's going to be about education. Because it is a DNA test, we need to understand that Māori have this concept of DNA that is linked to the tapu of whakapapa. So if DNA is our biological whakapapa, then we need to be careful when we're dealing with it. And frankly, I'm going to blame jet lag and just wrap this all up. So whakapapa is your biological DNA. There needs to be protections in place for that, but people need to understand what it is that DNA is. So the communication about ctDNA is just as important as the science that sits behind it to back it up. And then I'm going to pass over to Sandra, back to Parry, who is going to tell you a bit more about the science that backs it up and the projects that we've been doing for Healthier Lives. Kia ora.
Thank you, Jordan. So I'll just give you a bit of a rundown on the research we've done over the last few years in the Healthier Lives cancer part of the challenge. There's a lot of method development. I won't bore you with method development, but I'll tell you about 3 studies very briefly on colorectal cancer, melanoma and breast cancer. And then you'll hear from Cris and Sandra about the future projects and direction. So the 3 studies we did on colorectal, melanoma and breast cancer had all had a similar study design. People with advanced cancer who are undergoing some kind of treatment, chemotherapy, immunotherapy, or targeted therapy. And we took blood samples before each round of chemotherapy, and we got hold of some tumour material at the start of the treatment to identify mutations which we could use as personalised markers for disease burden. So here's one example from a patient with colorectal cancer who was receiving chemotherapy. This patient had a mutation in a gene called p53, a 818G2A change, so a particular mutation in this person's tumour. Here the arrows show the timing of, at the top there they show the timing of chemotherapy, and a big arrow is a higher dose to a small arrow which is a smaller dose. So you see here, and it just followed the blue line for now. So the patient started off with a chemotherapy called Capox, and initially, this is a log scale, so initially the tumour has decreased quite nicely with that treatment. And then something's happened to that patient, probably toxicity from the drugs, and they have had a dose reduction. And what you can see now is that, again, following that blue line, you can see the level of tumour has just started to kind of climb away again. So clearly the lower dose of Capox was insufficient to hold that patient's tumour at bay. And so all that time they were receiving that lower dose of Capox, it was futile treatment. They were not getting much benefit. Maybe it was growing a bit slower, but they were still getting progressive disease. So futile treatment. And then finally it's been switched out to a new chemotherapy, something more aggressive, FOLFIRI, and the patient has started to respond again. The red curve is a protein marker which is commonly used in colon cancer, and you can see it doesn't always go in the right direction and it is delayed in its response. So it's not nearly as responsive as the DNA marker. Here's another patient with two mutations we followed through the course of treatment, and that's the green and the blue lines, and you just see there's that space in treatment and that FOLFIRI treatment. The patient has again skipped a treatment or it's been delayed for some reason, and you see the tumours shot up in that little gap. But then fortunately it came back down again when the treatment was recommenced. So clearly the ctDNA has a very, very tight measure of the tumour burden and can be used to see really small and rapid changes in the patient's tumour burden. This is an example of a patient being followed through the entire course of his treatment from just after diagnosis through to when he passed away. And this really tells you the story of his illness. The different colours show different treatments he's received. They were both chemotherapies and immunotherapy. And you see the two markers we followed, the two different mutations we followed in this patient. They parallel each other, and you see the different response to different treatments. And you see the emergence of resistance at the end of that, the green period with that triple therapy in there, and then increasing difficulty trying to get the disease under control. So this is incredibly useful information for a clinician to observe in, not quite real time, but, very, very close to, that degree of resolution, how the patient is responding to treatment. It's also extremely useful for the patients themselves and their families to understand where things are going. So when things are going well, they can have a period of respite and think, well, this is good, we can be happy and relaxed and things are going well, and that's good, we can enjoy that. And when things aren't going so well, when the markers are starting to climb again, it can do two things. One, it can give the patient and the family some reason to go back to the clinician and say, come on, we've got to change things here, we've got to make a move, this is not working, we have to change the treatment. Or, in the worst case scenario, at least allow people to understand their situation and come to terms with what their likely fate is going to be. Just quickly, one breast cancer patient, same story, initial response to one type of chemotherapy, and then a slow climb back as the tumour came back after that therapy was stopped, and then a good response again when a new treatment was restarted. With melanoma, this is work done by Sandra, so what they saw there, they were following patients who had advanced melanoma and were receiving immunotherapy. And so this first patient here showed a very good response, so really high levels of ctDNA back at time 0, and then the levels came right down and largely stayed down. So a great response from that patient for that very expensive treatment. This patient was the opposite. The tumour just grew away despite the receiving immunotherapy. So in this case, it would have been probably wise to stop immunotherapy, would have saved the cost on for the individual and the state to keep on giving that individual that therapy. In this patient here, it's a mixed story. So initially, we look at the CT scans at the bottom there. Initially, the tumour was quite large, and then after about 120 days, about 4 months, the tumour shrunk away again with the next CT scan. And so the thinking would have been for the clinician to say, oh, great, the tumour's responding to immunotherapy. How good is that? But if you look at the ctDNA results, which are much more dense in their data, you can see, in fact, the patient started to respond really well, and then the tumour has started to climb back again. So, in fact, the trajectory of tumour growth is bad. The patient's disease is getting worse. And so for the clinician to make a conclusion that things are fine, the patient's responding, is incorrect. That patient has progressive disease and needs to have his or her treatment changed. Sandra's team also showed that ctDNA can be used as a prognostic tool. So if the ctDNA clears really rapidly after treatment, patients tend to have really long-term survival. So it's a very useful prognostic marker for melanoma and also other cancers too. So just a couple of quick take-homes. ctDNA blood tests are reproducible and are stable, and they provide a sensitive measure of tumour growth and treatment response. And so they provide a means for really responsive, optimised care of individual patients. I'll now pass over to Sandra, who will give us a rundown on what we're doing now beyond the challenge.
Thank you, Parry, for that great summary of the results. I was very fortunate to be involved and do the melanoma work during my PhD studies, and it was really the perfect vehicle for figuring out how to do this, how to get that sensitivity, the specificity. So it's been a great learning exercise. But now we get to go into the future directions, and this is a really exciting space. I'm going to present today some of the stuff that we're doing in the advanced cancer space. How can we use ctDNA analysis to really aim to get some treatment selection going for our clinicians? Early diagnosis, how can this technology be used to go out into the communities and help, like Jordon said, help these people in the rural regions of New Zealand, on the marae, to really figure out what the diagnosis is without having to go through the public health system. And I'm going to touch on a couple of projects that are just in the works but not yet undertaken. So when we really started to sit back after this initial tranche of results and think, well, what are some New Zealand-specific steps that really need to be addressed, and some of the cancer types that have got high need, we really, lung and bowel really stuck out as two of those cancers where ctDNA could probably make a significant difference. So I'm going to start with the lung cancer and how we're doing ctDNA analysis in this advanced stage. So quite often when you talk to the oncologists, they'll say that actually quite a lot of people will turn up into an emergency room with some symptom where they have a CT scan and they get diagnosed with advanced lung cancer on first presentation. The standard of care would be for these patients to then go forward and have a biopsy, which is a needle that goes into the tumour. Some of the tumour cells would then undergo histology so they could find a diagnosis of this tumour. It would tell you about the type of cancer and the stage. And then in some tumour types, like lung cancer is one of these tumour types, there's these incredible therapies called targeted therapies. And what it means is they're specifically targeted towards specific DNA mutations. So if there's any tumour cells left, they can extract the DNA and they can do a genomic profiling to see, can we detect any of these specific mutations that would allow us to give this targeted therapy. Now, these therapies are amazing. They have low toxicity and they work really, really well. So they give these patients back a quality of life that they wouldn't get on chemo. However, not everyone can have these because you need tumour cells. And the tumour cells, there need to be enough of them to extract the DNA and do the genomic profiling. So if you're elderly, you're frail, you've got comorbidities, having a biopsy is more likely to do harm than good. So this option is not available to them. So we thought this is a perfect opportunity where a simple blood test to analyse the ctDNA could then help with these patients to see, can we detect one of these specific mutations? Now this plot is an actual digital droplet PCR that we do in the laboratory, and it's soon going to be done in the clinic. In the green is the detection of the normal part of the gene, and in the blue, if you see any droplets in that blue, any blue dots, that is the specific detection of the mutation that will then let us directly prescribe that targeted therapy to these patients. So how are we actually starting to do this? This is the FAST study. It's a feasibility assessment study of how we can do this in advanced lung cancer patients. And this is headed up by Annie Wong, who's an oncologist and researcher at the University of Otago, Wellington, along with Kirsty Danielson, and up in Auckland, myself, Led Cameron, and others. And what this is actually aimed at doing is recruiting patients that are coming into the emergency room that cannot have a biopsy or there's no biopsy tissue available, and consenting them to give a blood sample. That blood sample is then going to be sent offshore for full clinical genomic analysis. That's not being done in New Zealand because it's not available at the moment, and it's exorbitantly expensive. However, if these patients have a mutation, then we'll be able to prescribe the targeted therapy. So alongside this, we're looking for a New Zealand equitable solution that's affordable. So we're going to have a blood sample as well and ship it up to Auckland. And I'm currently in the process of just starting the clinical validation of these assays in collaboration with LabPlus and Auckland Hospital. And all of this is with the purpose of developing a test that can be affordable, specific, and then allow our patients to access these amazing treatments. The second little segue I'm going to do is looking at the cancer diagnostics and how ctDNA could be used to hopefully help with an earlier cancer diagnosis. One of the sort of previous limitations of ctDNA was when you were looking at mutations, you're looking at a single nucleotide change on one chromosome. So in that early diagnosis space, when there's not much tumour burden, it's actually really hard to detect. But as Parry alluded to, methylation is something that is present on our DNA, and this is what controls gene transcription, gene expression. And what's really interesting is with this methylation, when you've got cancer, there's global changes to this methylation in the cancer tissue, and it acts almost like a fingerprint. So you can really start to identify what a cancer looks like from a normal. So it's hoped that this research will allow us to combine the mutation and the methylation profiling to make a far higher sensitivity biomarker test. And this is what's being done in Dunedin. So Parry and a whole lot of others down in Dunedin are working on both lung and colorectal cancer to try and get these tests that can be used out in the clinic, on the marae, in the rural regions, in the GP clinic. So they could be potentially used for standalone tests for people that have got high risk factors or family history. These people that have got symptomatic, but they're not eligible for the current standard screening. But it's also hoped that maybe they could be used as an adjunct to the proposed lung cancer screening, which we'll hear about, I'm sure, more tomorrow, or to the national bowel screening. So Parry and Jordon, you've been into the communities. The people want the test close to home that they can access. What's really amazing is ctDNA is exquisitively specific, so you do have a lower false positive rate. So hopefully you will ultimately have less false positives. And one way that this is potentially going to happen is with this unique little tool called the nanopore sequencer. Now, this is a handheld sequencing device that can be used basically anywhere in the country because it has limited laboratory setups. This is work that Jordon and Parry are doing down in Dunedin, and it's quite incredible that one day, hopefully, we'll have a test that can be spread out into the communities. Someone's alarm's going off. Finally, what's next? So this is just a couple of projects that aren't quite underway yet, but they have got some funding. The first one is looking at head and neck cancer. Up in Auckland, with a radiation oncologist and a surgeon and a cancer nurse specialist, we've got a small pilot study to look at head and neck cancer. Now, frequently, these patients have radical surgery for their disease, but quite often there is a high number that do end up with relapse. And even though there's some pathological markers that the clinicians use, it's not very good at sort of predicting who is going to go on to have further cancer. So what we're actually going to be doing is looking at the post-surgical lymphatic drains where the lymphatic fluid is drained off for about a week after surgery and see, is this a better source for residual disease after surgery, and then use this to help guide further treatment for these patients. The second project that's very exciting is an endometrial cancer. And this is a really great collaboration. We've got people from all over the country, including Claire Henry, who might still be here, and Karen Bartholomew and Sherry Blenheim. And this is where, in particular, we're looking at a specific clinical question. It's where there's an increasing rate of young women with endometrial cancer, and it's generally driven by obesity. Now, for a lot of these women, they don't want to have a full surgical hysterectomy. They want to retain fertility. And so they can go on a hormone treatment that can help them do this. But not everyone responds. And being able to figure out who is going to respond and who isn't is incredibly invasive, and it's time-consuming, and it has to be done in hospitals. So we're actually looking at taking swabs, and we just created some pilot data last week, and saying, can we use a swab to look at mutations alongside the methylation profiling between responders and non-responders, so that we can create a test that is much more straightforward and easy to help these women. So this work is ongoing, and it's an incredibly exciting space to be working in, and I'm very fortunate to have been part of the Healthier Lives initiative. And I'm going to pass off to Cris now, who's going to wrap this all up. So thank you.
Oh, kia koe, Sandra. Nā mihi kia koutou katoa. Tēnei taku pepiha I whanau mai au I te pūtake o Rohini. I tipu au I te taha o te awa o Manatū. Kei tamaki makara aho ina hu ana ina nei ko Kristen Print taku ingoa. Kei te tiketa kōrero I a tātou tupuna. Kimi hia katoa nā pūtake o te kaupapa. Ina I kitia kimi hia te rongo. No reira, tēnā koutou, tēnā koutou, tēnā katoa. Well, look, thank you very much. I've got the job of wrapping this up. The whakatauki I you used there, sorry, I'll just advance this on one more, was something that Matua Kepa Morgan alerted me to. And I absolutely love it, and I think it's incredibly well focused for the National Science Challenge work that we've been so lucky to be part of. Look at all facets of the challenge and the understanding that provides, therein lies the solution. Isn't that lovely? And I think that's very much what this challenge has done. We've had a focus on equity, outcomes, a focus on working very closely and being led by our Māori and Pacific partners. We've, I think, been very lucky to be part of a community of research with clinicians and patients, in particular patients and their whānau working together. And as you heard in the first steps, we were very lucky to build enduring partnerships and to have our partners allow us to make a few mistakes and learn from them. We've done some really complex and actually quite difficult molecular work, which Sandra and people in Parry's lab are really just sort of talking down a little bit, but that was world-class, excellent work from these people, and I think it was a fantastic start. Beginning in colorectal cancer and melanoma and then spreading out. And now, of course, as you hear, we're moving into other cancers and really implementing this in the context of the ecosystem of precision medicine that's moving in New Zealand. And Sayali Pedharkar very kindly gave a wonderful introduction to this. Sayali talked about the long-term insights briefing, the first insights briefing from the Ministry of Health, Manatū Hauora. And several of us in this room were lucky to be part of the Kia program, which also started to work towards understanding how the New Zealand health system can utilise precision medicine. But the whole point of ctDNA and other types of precision medicine is it simply opens this much wider window onto the biology of what's happening in an individual patient. So that individual patient with their clinical advisors can make much more intelligent and informed decisions about their treatment, their care. Everyone asks about the health economics of this, and it's a really hard area, ctDNA, to do health economics on. A lot of people say, does ctDNA save money? And I'm sure it can save money. You've heard about the huge number of applications that ctDNA can be applied to, but I think what often has ended up happening in many overseas trials is that the ctDNA, adding it to clinical care, doesn't change costs very much, but it really increases the excellence of care for individual patients in their whānau. And here's an example from a Canadian study in a very particular time back in 2020, 2021, with a very particular clinical situation, advanced non-small cell lung cancer patients who are presenting at a late stage. And the study compared the costs of everything from treatment, testing, the whole gamut, with just having standard tissue testing, like Sandra told you about, to having the tissue testing plus the ctDNA. The standard tissue testing's on the left. So the testing cost increases about 146% when you add in the ctDNA, but it's still only 2% of the overall cost. But the number of genetic alterations that are detected that can then allow you to personalise treatment for a patient's cancer right at that point of time increases about 15%. And what that does in this particular study is it means the preferable treatment for these patients, which is therapies which may or may not be available in New Zealand, but we're in the study, that target the specific mutations in the cancer, can be given. So actually you increase the cost of the targeted therapies. You're increasing it 37%. But at the same time, the default therapy that these particular patients received at that time, which was a combination of chemotherapy and these advanced immunotherapies, which is really expensive, that drops because fewer patients are receiving that. More patients are receiving the preferable targeted therapy because you know what mutations their tumours have. So the balance of the gaining of cost but better care with more targeted therapy and the reduction of cost because less patients are receiving the default immunochemotherapy comes out almost cost neutral. So the bottom line is that more patients receive the right treatment for the same cost. And that's what I see as the most wonderful outcome of this. So I remember when Parry and I were first talking about this challenge, Parry had the wonderful analogy of moving from the hospital on the hill to the clinic on the marae. And I think that's really what we're trying to do and what Sandra has tried to demonstrate. We have a massive way to go here, but we're very lucky in that there is increasing energy in New Zealand to generate a precision medicine ecosystem. Some really good exemplars are starting to emerge, many alongside ctDNA. I think the key to this is energetic partnerships with Māori leadership, Pacific leadership, partnerships between brave clinicians who are willing to try different things with and for their patients and scientists. For me, I think the key, though, is this virtuous cycle that I've got in these orange boxes and blue arrows, where ctDNA and other precision medicine technologies can improve precision healthcare for patients now, but at the same time, the same information can be used to better understand cancer and to deliver better precision healthcare in the future. So I will now pass over again to Parry to sum up. Kia ora.